Thank you very much, Professor Eds. Thank you to the meeting organizers for inviting me. And my assigned topic is earlier diagnostic strategies, a hematological perspective. These are my disclosures. A talk like this is a bit like preaching to the choir. For those of you who may not be familiar with that phrase, it means that you're trying to make believers out of people who already believe. It's like the priest or the minister preaching to the choir, to the converted, whereas it's the people who are not there who really need the message conveyed. So in a way, that's what this is like, preaching to the choir, because you people are all, or at least most of you, are quite familiar with Gaucher disease and the diagnosis. I have a general assumption, and that is that most persons who are diagnosed with Gaucher disease type 1 before age 18 will need treatment sooner rather than later. In other words, they are more likely to have moderate or severe disease than they are to have mild disease by the very fact that they're picked up at an early age. Although that's not always true, but most cases, I would say. So the question is earlier diagnosis really important? And if so, why? Somebody suggested to me recently that the earlier the diagnosis is made, the more information we have about the natural history of Gaucher disease. Now, I've put a question mark there. Why? Because that is true only if the person remains untreated. Then you have the information about natural history. If you start treating the patient early, then immediately it becomes unnatural history, or the history of treated disease rather than the history of rather than the natural history of the disease. So there's a question there. The second point is that if patients are having progressive disease, the earlier treatment may prevent some complications. Who needs to hear our messages? Not so much the people who are here. As I said, we're preaching to the choir. The people who need to hear the messages are people like the general internist that Ari mentioned in the case that he showed us of the patient who was seen in his own hospital and never got diagnosed until 2 years later. And it's seen by general internists in a hospital where Gaucher disease is a big thing. So those people need to hear the message. General pediatricians, not pediatricians who specialize in metabolic genetics or hematology, but the ones who are the general pediatricians out there in the community, they need to hear the message. Family doctors and general practitioners need to hear the message. And surgeons. Why surgeons? Because we've had a couple of patients in our Gaucher population who've had their spleens whacked out by surgeons because they just presented with big spleens. And the surgeon thought it'd be a good idea to take the spleen out and get the diagnosis. Well, that's really not on in these days. And even general hematologists, again, Ari showed you the picture of, or the reference to Pram Mystery's article from several years ago, where general hematologists were given a series of symptoms and presentations, and many of them did not even come up with the possibility of Gaucher disease. Now, I've put the next people down with question marks. So, oncologists, why? Because we know that multiple myeloma, the incidence of myeloma, is greatly increased in Gaucher disease. And if an oncologist has a patient with myeloma with a big spleen, because you don't usually get splenomegaly in myeloma, then they should think about maybe some other condition going on. Although presumably the patient who with myeloma will have already had a bone marrow examination, and hopefully the Gaucher cells would have been picked up on that bone marrow examination, although not necessarily. I've put down neurologists. Well, we all know the connection that's already been alluded to between Parkinson's disease and Lewy body dementia. So again, if a neurologist sees a patient with one of those conditions, and the patient also has a splenomegaly or thrombocytopenia or both, maybe to twig, possibly this is Gaucher disease. and also respirologists, or as they're called in the States, pulmonologists, because of the low but definite increased incidence of pulmonary hypertension in Gaucher patients. And finally, hepatologists, again, because of the increased incidence of liver problems. What exactly are these messages that we need to get out there? First of all, splenomegaly with cytopenias, which is probably the most common presentation in all of Gaucher disease. And again, if you see somebody with thrombocytopenia and a big spleen, ITP should not be the first consideration. Second point, splenectomy is now a no-no unless absolutely essential. And there are cases where it does become essential, but not very commonly. Now that treatment is available, which is my third point here, that treatment is available, and a lot of people still don't know this. Even some of our hematology colleagues aren't aware that that treatment for Gaucher disease is now available. They still keep patients in the dark. Another presentation, high ferritin with a normal transferrin saturation, not that uncommon. And another presentation would be with bone problems, a bone crisis, or chronic bone pains, or X-ray appearances that suggest that one is dealing with a malignant metastatic disease, as has been sometimes told to our patients whose X-rays have been viewed by people who are unfamiliar with the fact that Gaucher disease may present with this kind of appearance. You've already heard about monoclonal gammopathy of undetermined significance and myeloma, and in any of patients who present with those possibilities with splenomegaly, you should always think about the possibility of Gaucher disease. And finally, as I mentioned a few minutes ago, if a patient has Parkinson's or Lewy body dementia and has then concomitant splenomegaly and or cytopenias, that has to be a possibility to be taken into account. How do we deliver the messages? The town crier. Well, several possible ways. First of all, give talks. Not this talk like today, because you people already know about these things, but talks to people that may not know about this. So talks to, general internists or general pediatricians. Secondly, the Canadian Hematology Society has a newsletter that goes out about 3 or 4 times a year. And they've recently instituted a series of unknown cases. So in each newsletter, there's a history and physical findings and lab results. And then readers are invited to send in their ideas as to what the diagnosis is. So we are in the process of putting together one of those cases of Gaucher disease. And this will reach a general hematological audience in Canada, because almost all hematologists in Canada are in the Canadian Hematology Society and therefore get this newsletter quarterly. I've put a question mark with the internet. As you know, there's a lot of crap on the internet, a lot of non-valid stuff, but there's also a lot of good. And it's possible for a patient to go onto the internet if they have certain symptoms and their doctor is unaware. We actually had one patient that, although she didn't go to the internet, she had a big spleen and she had thrombocytopenia. She was an older woman. She was in her 50s at the time, I believe. And her doctor didn't know why this was the case, but she ended up reading in a book. And she saw that she had some of the symptoms that were present in patients with Gaucher disease. So she went to her doctor and said, "Could I have Gaucher disease?" And the doctor said, "Not sure." So further testing went on, and indeed, she did have a diagnosis of Gaucher disease. So sometimes the patient themselves can be the instigator. And we've had another instance where a patient who has been followed by a hematologist for 30 years with thrombocytopenia getting worse, finally went to the internet, found the National Gaucher Foundation of Canada, found that we had a center in Toronto, and this woman who lived out on the outskirts of Toronto got herself referred, and indeed she is now on enzyme treatment. So sometimes the patient can take their own initiative. And finally, I put down medical school. I think it's unlikely we're going to get any more lectures in rare diseases in medical school. Nowadays, there's so many other courses that they've introduced into medical school, all these touchy-feely courses like, social aspects of medicine and medical ethics and occupational medicine and so on. And I think it's very unlikely that we're going to get increased inroads as far as Gaucher disease is concerned. But, some people may not want to hear the message or may not want to act on it. So we've got patients one in particular who was diagnosed with Gaucher disease about 17, 18 years ago, and she's very reluctant to come for follow-up. In fact, we had to beg her to come back a couple of years ago when she hadn't seen us for 5 or 6 years in the interim. Now, fortunately, she hadn't progressed, but still, I think she should be followed up more closely than that. However, some patients don't like the idea of having a label of being a patient with whatever, so they're not comfortable with that. I'm going to go through a couple of, three actually, case outlines and just talk them over with you. The first is a woman 30 years old at the time she was referred in 1996 because of possible idiopathic thrombocytopenia, or ITP. She had been having platelet counts ranging from about 100 to 120, and when we examined her, we actually found that she had splenomegaly. Not markedly so, but 4.5 centimeters below the costal margin. Her liver was dull to percussion 3.5 centimeters below the costal margin, and these findings were confirmed by ultrasound. Her parents were from the same village in Greece, but apparently not related, although who knows, going back, several generations. Her hemoglobin, as you can see, was in the low normal range. White cell count also in the low normal range. Platelets, I've already said, mildly reduced. Her beta-glucosidase levels was definitely low, and her DNA showed N370S associated with R463H. Her skeletal survey showed only the Erlenmeyer-Flask deformity, which I think you are all familiar with, the undertubulation of the femurs, of the lower parts of the femurs. And her bone mineral density was normal. So, what would be your next step? Would you start enzyme therapy at either 15 or 30 or 45 or 60 units per kilogram every 2 weeks? Would you follow her closely with frequent monitoring? Would you do a bone marrow first to rule out a myelodysplasia or other hematological disorder, or some other strategy? So take a few seconds to... So we have a plurality, not a majority, but a plurality of patients taking choice D, which is starting enzyme therapy at 60 units per kilo. And then the next one would be the blue one, 18% starting enzyme therapy at a low dose. 15% of the patients chose E. And I think that's about it. So those are the main choices. 13% chose starting enzymes at 30 units per kilogram. So what did we do? Here's her follow-up. We followed her closely. And I show you the results on the left-hand side, which were the initial results, and on the right-hand side are the current results up until the end of 2014, which was a few months ago. Her liver is certainly no larger. If anything, maybe a bit smaller, and the same with the spleen. Her hemoglobin has remained stable as her white count has dropped slightly. Her platelets have remained stable in around the 100 range. Her ferritin has ranged between normal and slightly elevated. She did have, excuse me, she did have a slight decrease in her hemoglobin in 2 out of her 3 pregnancies. Her chital levels haven't really changed. Her bone mineral density remains normal, and her MRI of her bones also remains normal, with no evidence of avascular necrosis. So, here's a case of an example, and we continue to follow patients like this closely if they're not on treatment, and she has done very well without any treatment at all. Second case, this is a 31-year-old woman, Ashkenazi Jewish origin, referred a couple of years after that in 1998 because her ferritin was elevated, but she had a normal transferrin saturation. She had been seen a couple of years earlier by another hematologist because of this high ferritin, and that, excuse me, at that time she had some nonspecific arthralgias, which were no longer present at the time we saw her. So the hematologist thought, well, you know, ferritin is an acute phase reactant. She had arthralgias. Maybe the high ferritin was associated with that. No specific diagnosis was made. I don't know for sure, because it wasn't documented in the record, whether they realized that she had a big spleen. She had quit smoking a few years earlier, and over a period of a few years gradually gained weight, so she went from 50 to 80 kilograms. Quite a big increase in weight. And when we saw her, she was overweight and actually in the obese range with a BMI of 32. Otherwise normal. Now, it was an abdomen that was very difficult to palpate, no question about it, because of her obesity. But we did do further studies thinking about the possibility of Gaucher disease because of the high ferritin and her Ashkenazi Jewish background. And lo and behold, she had actually a normal CBC, but her ferritin was elevated with a normal saturation. And on CT scan of the abdomen, she did have mild splenomegaly. Her DEXA showed normal bone marrow density, her skeletal survey was normal, her beta-glucosidase was low, and she was N370S homozygous. So the question here is, would you treat this woman either yes, no, or not sure? Didn't work? Try it again. Okay, let's try it again, please. A, B, or C, or 1, 2, or 3. Okay, so 31% would treat the woman, 43% would not, and another 26% not sure. Okay, what did we do? Well, here's her follow-up. So this is now a 17-year follow-up. She was seen every 6 to 12 months during that time. Her hemoglobin has ranged between 114 and 128. Her white cell count has been normal. Her platelets have ranged from slightly low to normal. The latest platelet count is 135. Her spleen has ranged from 15 to 17 centimeters, the latest being 16 centimeters with a normal liver size. Her ferritin has ranged from the normal range up, for the normal level up to slightly elevated, up to 700, latest one being 407. Her Chido has shown quite a range from 400 to 2,000, the most recent one being 1,700. And on the DEXA scan, she has had normal bone marrow density every 2 years until this past January, when she has shown a decrease a 10% decrease in her left femoral neck, and 6% decrease in her total left hip. So we are about to start this woman on enzyme treatment in the very near future. But you can see that over a period of 17 years, there was very little progression. And this is in contrast to what some people have said, that Gaucher disease is always a progressive disease. I've shown you two cases in which there's been very little or no progression over a period of many years. And there have been reports in the literature. Beutler's group initially, our group has reported series, and so have the Dutch group. So just to point out that just making an early diagnosis doesn't necessarily mean that the patient has to be treated. The last case is a 23-year-old man who was a university student when we saw him. We saw him four years ago for the first time. His mother said he had always been sickly as an infant. He had had several hospital admissions for cough, failure to thrive or to grow. And he actually had been seen at a children's hospital in another province 6 years earlier. And at that time, they found his platelets to be slightly low at 125. For some reason, they did a cystic fibrosis test. I don't know why, but it was negative. No specific diagnosis was made, and he ended up going back to his home province, which is in northern Ontario. He did, at the end of 2009, have a crisis, a bone crisis, painful bone crisis, which lasted about a week. And although he got over that, he did persist with having generalized bone pains. He also complained of spontaneous bruising. He had frequent nosebleeds, and anytime he cut himself, he would ooze excessively. He had marked fatigue, which had been worsening over the past year. He was in university. He could just about make it through classes, but in the evening when he was supposed to do homework, he just didn't have the energy to do that. He was seen by an internist who was quite sharp, and she ended up doing a bone marrow. She didn't realize that there is a diagnosis you can do for Gaucher disease, but she thought that there was something going on because of his splenomegaly and thrombocytopenia, so she did a bone marrow which showed Gaucher cells. She also did a CT scan of the abdomen, which showed him to have quite a splenomegaly with numerous hypodense lesions in the spleen. You can see his ethnic background there, half Ukrainian, quarter Czech, and then a little bit of British and French thrown in. Interesting thing about him is that 4 relatives on his paternal side had have or had Parkinson's disease. When we saw him, he was 65 kilos, looked a bit scrawny, 172 centimeters. His spleen tip was definitely palpable. His hemoglobin was a little bit low for his youth. His white cell count was low normal, and his platelets were definitely low. His Kito was 4,000. Ferritin was elevated. Interestingly enough, his secondary coagulation studies were all normal. So it was only the thrombocytopenia, which probably some platelet dysfunction, although we did not do platelet function studies. So further investigation showed that he had diffuse marrow changes in his femurs and lumbar spine consistent with Gaucher disease, but no AVN and no Erlenmeyer-Flask deformity. MRI of his abdomen, he definitely had a spleen that was 7.5 times the multiples of normal, and it had multiple nodules. His liver size was normal. His DEXA scan showed a normal bone mineral density. His beta-glucosidase was low, and his DNA was N370S and L444P. Would you treat this man? Yes, no, or not sure? Well, it's almost a no-brainer, isn't it? 86% would treat this man, and I think that's where we agree. Let me go on to the next, okay. So he was started on velaglucerase at just over 60 units per kilo every 2 weeks, currently down a little bit to 50. He showed marked improvement, both physically and mentally. The man is he's a new person. He's changed so tremendously. He's become a confident now person who's pursuing 2 degrees at university. He's actually talking about possibly going into medicine. He still does fatigue a little more than usual. His weight, he's gained almost 10 kilos, from 65 up to 74.5. His hemoglobin has come up well within the normal range. Platelets are also in the low normal range. Chito has come way down. Spleen has gone from 7.5 times multiples of normal to down to 2.8, still with some nodules. His bone mineral density remains normal, and the interesting thing in his MRI is that there's no longer any evidence of bone marrow packing. So you can see here, this is the dark area here showing the marrow infiltration with Gaucher cells, and this is pre-treatment, and this is now the most recent one showing this is completely cleared, and the evidence of bone marrow packing has disappeared. So, thanks to yoga, I now gently stretch to conclusions instead of jumping to them. So, what are my conclusions? So, some conclusions that I've come up with are, first of all, that earlier diagnosis may offer the opportunity not only to treat, but in some cases to follow the natural history of the disease, which we did in the first two cases. Secondly, the early diagnosis may be less in our hands than in the hands of other people out there in the community. General internists, general pediatricians, general hematologists, and so on. And I think there are limited ways of getting our message across. I mentioned some of these. I mentioned giving talks. I mentioned putting cases in newsletters. And I mentioned patients themselves going on to the internet. But how do we actually go about drawing these patients out of the bushes is not easy to say. I think there are limited ways of doing that. So with that, I thank the organizers. I thank my people at the Gaucher Center at Toronto, and I thank you all for your attention. Thank you.